Question 1. A 17-year-old basketball player collapses and dies while playing a game. Which of the following is the most likely cause? A. Coronary artery disease. B. Pulmonary embolism. C. Hypertrophic cardiomyopathy. D. Subarachnoid hemorrhage. E. Spontaneous pneumothorax. Answer is C. Hypertrophic cardiomyopathy. Summary. Answer C. Hypertrophic cardiomyopathy is the most common cause of atraumatic sudden death in young athletes. Choices A, B, and D are far less common in this age group. Choice E can occur in tall, thin athletes, and although death may result from tension physiology, it is almost never sudden or without preceding symptoms. Question 2. A 32-year-old woman presents with recurrent episodes of headaches, palpitations, and profuse diaphoresis. Her primary care doctor diagnosed her with an anxiety disorder after her thyroid function came back normal, but various selective serotonin reuptake inhibitors have been ineffective. In the ED, her vital signs include a temperature of 99.0 degrees Fahrenheit, a pulse of 90, and a blood pressure of 175 by 100. Which of the following is the best agent to treat her hypertension? A. Metoprolol. B. Hydrochlorothiazide. C. Phenoxybenzamine. D. Nifedipine. E. Enalapril. Answer is C. Phenoxybenzamine. Summary. Answer C. This patient has a pheochromocytoma. Pheochromocytomas are catecholamine-producing tumors that account for 1% of cases of hypertension. They are most commonly found in the adrenal medulla, although 10% are extraadrenal. The rule of tens in pheochromocytoma: 10% bilateral, 10% malignant, 10% extraadrenal, 10% associated with familial disorders, example, multiple endocrine neoplasia. The diagnosis is based on detection of urinary metanephrines and vanillylmendelic acid, VMA, and has a diagnostic sensitivity of 98% for detecting pheochromocytoma. Assays for plasma metanephrines may also be performed. Finally, CT or MRI is used for tumor localization. Hypertension has traditionally been treated with phenoxybenzamine, an alpha blocker, whereas beta blockers should be avoided. Beta blockers lead to unopposed alpha stimulation, which may result in a worsening of hypertension. Due to associated peripheral edema and orthostatic hypertension, other alpha blockers have also been used, such as terazosin or doxazosin. Question 3. Which of the following is indicated for treatment of a stable, wide complex regular tachycardia at a rate of 200 in a patient with Wolff-Parkinson-White syndrome? A. Adenosine. B. Amiodarone. C. Esmolol. D. Digoxin. E. Procainamide. Answer is E. Procainamide. Summary. Answer E. WPW syndrome is the most frequently occurring accessory pathway syndrome. Patients have an accessory conductive pathway, bundle of Kent, from the atria to the ventricles, which pre-excites the ventricular myocytes before the AV node conducts the normal sinoatrial depolarization wave. As a result, patients with WPW have a shortened PR interval and a delayed QRS upstroke, called the wave. Patients with WPW syndrome can have reentrant dysrhythmias, in which the accessory pathway can either conduct in a retrograde fashion producing an orthodromic pattern, in which the AV node conducts in the normal direction, which results in a narrow QRS complex, or an anterograde fashion forming an antidromic pattern, in which forward, or anterograde conduction occurs through the accessory pathway first before cycling around to pass through the AV node backward, which produces a wide QRS complex since the initial conduction does not utilize the Purkinje system. A patient with WPW syndrome, tachycardia, and wide QRS complexes suggests the presence of an antidromic conduction pattern, where the accessory pathway conducts anterograde and the AV node conducts retrograde. Agents with relatively pure or isolated AV nodal activity such as adenosine or verapamil, which are the preferred agents in orthodromic reentrant tachycardias in the setting of WPW, are contraindicated in this circumstance, as inhibition of the AV node will promote faster conduction through the anterograde accessory pathway, which may cause degeneration into an unstable rhythm such as ventricular tachycardia. The treatment of choice in stable antidromic or irregular tachycardias in WPW patients is Procainamide, while Amiodarone is considered a second-line agent. Unstable patients require cardioversion. Question 4. Which of the following is true regarding prosthetic heart valves? A. Bioprosthetic, porcine, valves require anticoagulation therapy with Coumadin. B. Prophylactic anticoagulation should be maintained at international normalized ratios, INRs, between 1 and 2. C. Chronic hemolysis occurs in most patients. D. In patients with mechanical valves, auscultation of a metallic closure sound indicates serious valvular dysfunction. E. Endocarditis develops in most patients. Answer is C. Chronic hemolysis occurs in most patients. Summary. Answer C. A small degree of chronic hemolysis occurs in all patients, which in most cases is clinically insignificant if appropriate iron supplementation is instituted. Mechanical, not porcine, valves require anticoagulation with Coumadin, and the INR is generally kept between 2.5 and 3.5. Mechanical valves always have a metallic closure sound. Absence of this sound indicates valve dysfunction. The risk of endocarditis depends on the length of time the valve is functioning but occurs in less than half the number of patients.